a lot of patients come in with already existing dentistry, and I think it's important to, when we're trying to figure out these wear cases, is what initiated it. Not just how do we treat it, but if we can understand healthy occlusion, then we can understand better how to treat occlusion that's failing, or why does wear occur. So comprehensive approach in evaluating the masticatory system is necessary to understand the individual patient's needs regardless of their initial presentation. And right is my practice in that picture there. We have a nice town in Winnetka, Illinois. Right, so I called the Pankey Institute my home base about 25 years ago, after I had already been a CE junkie for a number of years. I was holding back from going to Pankey just simply because it was, at the time it was like a week long, and it was expensive. But then when I got there, I went, wow, this place was worth that and more. And I went there really to learn technical expertise. And what I found out is that really to be a better technician, I really had to get other parts of my life in order, and understanding behavioral needs and managerial needs, and how to balance my life. And so the Pankey Institute provides a great place to give you your home base, so you get real sound fundamentals, and you can go enjoy education elsewhere to kind of complement that. And for the last 20 years, I've assisted and taught at the Institute, and I look forward to every one of my opportunities, because there's never a time I go there and that I'm not pressed to and challenged by dentists attending and other faculty that keep pushing forward to learn more. Been a great run, and I hope I still have a number of good years left. On the right is one of the study groups that I participated in, and if you don't belong to a study group, I encourage you to do so, because this is really where you put your education to the learning, and you have a safe environment to do so, besides just working on your family and friends. If you need to get involved in a study group or would like to, you can contact me and the Pankey Institute, and we'd be glad to set you up in the right type of group. So disclosure statement, I'm not being paid to present this lecture, though at times I do earn an honorarium for my teaching and facilitation of study groups. I haven't altered any images of my clinical dentistry, and I'll be touching lightly on many subjects. Many would take a lot of time to talk. We don't have all that today in an hour, but please do not ignore other issues, especially such as sleep apnea and airway issues. You can feel free to email me or the Pankey Institute for if you see some of these subject matters where you want to continue your education. Since we're limited on time, your questions are welcome via chat, and we will address them if at all possible during the presentation. I welcome to be interrupted, so you can make sure you're understanding where we're at in the discussions, and afterward we will save some time also to continue if you stay online after the So tonight's subject matter is diagnosis and sequencing treatment for wear and complex restorative cases. So we really need to understand when we have pathology, and to do so we need a good examination and records. And in treatment planning, we're really looking to do the least amount of dentistry that will provide the most predictable results to meet the patient's needs, patient's and goals of treatment. And then we have treatment sequencing. How do you get it done for the patient in a way that fits their needs? And sometimes that matters with financial. You have to segment treatment and whatnot. So for signs of occlusal pathology, we have obviously wear can be a very obvious sign, and you have different problems with wear: bruxism, abrasion, chemical erosion. A number of factors can play into that. Abfriction, we'll talk a little bit about that, fremitus, cracked teeth, and occlusal muscle and TMJ dysfunction. So how we define health and successful treatment, it really depends on how we define symptoms. Are the symptoms that you are taking in from the patient, is it just from a health questionnaire? Or are you really sitting down and having an interview with them and having discussions, diving a little deeper into signs? Are you, when I was in dental school, I was taught to examine a number of things, but when I got out, I felt like when I was doing 3 hygiene checks an hour in practice, the signs I was looking for was perio disease and just decay, basically, and sometimes a few other things. But how deep are you looking in your examination and evaluation for signs of pathology? And then pathology itself, what do you define as pathology? So we'll start with a case. It's always great to look at teeth, and these were taken by a local colleague of mine, an excellent orthodontist who teaches a lot about airway and development. He had a difficult case he was working on, and severe wear, and these were his photographs. And the teeth, I would tell you from a age standpoint that, you know, I'd say a person who's 60 years old doesn't typically have this much wear. Well, Dan was basically about 40 years old, and so his concern was, yeah, his teeth were wearing down, and really, I don't think he really understood his teeth were wearing down as much as his wife was complaining he doesn't look like he used to look, and he didn't have any teeth left. Kind of often his teeth weren't very visible. So that's kind of obvious that's occlusal pathology. In this particular case, if I said this person was 6 years old, you'd say, oh, that's not much wear, and so maybe that's not really pathologic in nature. But this person was only 21 years old. So I was pretty alarmed by it when I saw that, and we'll talk about her a little bit later. And this person has very nice looking teeth. And, you know, if I saw that person at 21, I'd say, oh, okay, that's pretty normal, but she's almost 60 at this point, and her teeth were in great shape. So these are the types of people you wonder why they're like that, and what is it about their occlusion that makes their teeth last so long. So occlusion to maintain health, we'll just read through this quickly. Upon light closure, so with the condyle seated and with a stable joint, all teeth contact evenly. And then when you close firmly, there should be no deviation in any direction. Upon any excursive movement, no posterior tooth will touch before, harder than, or after an anterior tooth. That's in an Angles Class 1 occlusion. Not all healthy occlusions look the same, and a healthy occlusion is dependent on the adaptive capability of the patient. A non-stressed, imperfect occlusion may be preferable over an overused ideal occlusion. It's really how often do you stress the system. How a patient uses their teeth is equally important as the occlusal arrangement. So we look at these teeth, we talk about wear. This is not necessarily occlusal wear. I mean, there is some obviously there too, but you see a lot of what's really impressive about this is the abrasion at the necks of the teeth. So is this abfraction? And I hear that a lot. That basically came about when I started as a dentist in the 80s. It didn't exist until then. I mean, it certainly wasn't a popular subject matter. And I will tell you that after I kept looking at it, and I was treating occlusion early on in my career, and I still saw things like this happen. This was a patient I had filled in with composites in these class 5 lesions, and lo and behold, there's some more abrasion in there. So abfriction is really what I would tell you you're more often seeing than actually abfraction. And does abfraction exist? Yes, I believe it exists in some unique circumstances to some degree, but pretty much in my area, it's from too much use. So if we go back to those first pictures I showed you, if we look at the pattern and the angle of the wear of that, you can actually see these lines are pretty much parallel to each other. Well, that kind of is an open and shut case in my mind that this is toothbrush use, I should say. So now another thing that we often see is erosion. And if I told you this was a 60-year-old person again, you'd probably say, oh yeah, okay, well I do see that in older people, but this isn't a 22-year-old person who came in my office this past 2 weeks, and his parents came in because their physician, pediatrician, told the young man, and he's handicapped, by the way, that he probably has GERD. And so yeah, that's a possibility, but I could have just gone with a health questionnaire and where he would have marked off, yeah, I have, you know, acid reflux and whatnot. But talking to him about his diet, he ingests an incredible amount of fruit juices. So, and looking at his top teeth, we see not nearly as much erosion. So I do believe that's something to do with acid. We're still trying to figure it out. But toothpaste also plays a role in this, by the way, because that's why you have ditching in those occlusal tables that's below the occlusion. So those points of dentinal exposure are subocclusal, so to speak. So it's a combination of problems in this person. So going back to the young person with the wear on the front teeth, we wonder, how does this happen? Is it because she's biting on something like her front teeth or some object? But their teeth really don't line up unless you take her out to some extreme movements. And we call this crossover. This is something that is not often looked at, especially in occlusion studies. They don't go beyond the cuspids. So I'm not going to get into literature tonight, just simply because I could quote you any literature you want on, in favor of what I say and probably against what I say. So anyway, occlusion literature it all depends on where you're looking. And the question for this person is, when do you want to fix it? You're 21 years old. Do you think you should fix this now or should you wait? Basically, on a case like this, the treatment very simply is just adding some composite and refining off some of these sharp edges on the teeth. And that's what I would tell you is something that you can be doing regularly in your practice. And here's that person I showed you earlier, so she has this chevron shape in her anterior teeth, and she's also got those non-curious cervical lesions. But how do we take care of the chipping? And what she was really concerned about was her front teeth started kind of bowing in. So again, same thing. I just do a little very conservative preparation of the incisal edges, and I bond some bonding material in there. This stays very long as you have your other ducts in order with the occlusion that I first gave you the definition of a healthy occlusion. Have your guidance on those front teeth and don't be the back teeth in your excursive movements. So before and after on this patient. And so a lot of people, and I've had a number of associates over the years come in my practice, and they look at my patients and they go, wow, that stuff really lasts long. And I say to them, well, why aren't you doing this for your patients? I get patients in my practice all the time that come in with this type of wear. And they've been seeing very good dentists at times. And I just wonder why more people aren't doing it. So if we know that healthy front teeth help protect the back teeth, and occlusion is basically mutually self-protective, meaning the back teeth help the front teeth and the front teeth help the back teeth, why aren't more people taking care of them? And can you help educate the patient? So a way to do that, and hopefully you can see me, and Mac, let me know if I'm visible or not, but I'm going to ask you all to take your fingers and put them on your masseters, if you can see what I'm doing, and some about the mid-masseters on both sides. I'm gonna pump my back teeth together, and my fingers will bow out, and I have my patients do this. So my fingers are pumping out, and then I move my lower jaw forward while I'm doing that. I've got my muscles clenched, move my lower jaw forward, and lo and behold, the muscles go in, my fingers go in, the muscles stop pumping. So I do this with pretty much every patient that comes in my office to educate them about their bite. And I get a lot more understanding from them than I do most dentists when I talk. Not saying that once you do this exercise, you won't understand it, but it's just simply that it is, all you have to do is maintain those front teeth well enough and give some anterior guidance, and you will save yourself a lot of trouble on the back teeth. So posterior wear. So as the TM joints change in dimension due to natural aging processes or undue stresses, the condyles will seat more superiorly, thereby necessitating the need for the most posterior teeth to wear and lose vertical height. Well, the anterior guidance has to be retained if the goal is to minimize posterior wear. And is it really good to over-engineer the resistance of our restorations to wear on the most posterior teeth? That's what I have a huge issue with looking at restorative materials for posterior teeth. My understanding is they keep saying zirconia is getting softer, but I'm not going to trust that until somebody else does it for a long time. Very few people can you see their second molar, so I'm still an old-fashioned guy with putting gold in there, and I think my patients appreciate that. We certainly can cut costs sometimes by using other materials, but I would be careful and understand what you're doing. And if you explain it to your patient, they may be willing to bump up their expense or their budget to put gold in their mouth. Well, what do you see back here? pretty much if you look at those molars, first molars and second molars, you see them ditching out and wearing down. So these teeth are adapting to the wear, but there's also cracking going on in those teeth, so that's not necessarily good. So wear is okay, but you don't want it to become excessive, and the problem with what's going on here is it's getting a little too deep. So when we look at these a little closer, you can see the cracking and how deep those fosses are getting. And the teeth above, which have plunger cusps, are actually digging deeper and deeper, and those cusps are getting sharper and sharper. So this is a kind of self-perpetuating problem. And so when we think about what teeth originally started at, you have like basically a point into a plane, but as it keeps digging into that hole, it's like going through a pothole, and it gets broader and bigger, and things start getting worn out, and your occlusal tables start looking wider, and again, the problem becomes a bigger problem if you don't address it sooner or later. So what is another very simple thing you can do in your practice right away to help stopping wear or correcting wear is you go ahead and round off those cusps. Take down a little. Obviously, don't expose dentin if you don't have to, but if you are getting close to it, you have to decide, hey, is this a tooth I really want to do this on or not? And you better inform the patient if you are going to expose some dentin, because they will need other treatment. But if you want to save those back teeth from cracking and splitting, you need to do something. And so here's just before and after both sides, and then the lower teeth, and I put crowns, and I actually put a filling on the other tooth. So one tooth needed a crown where it was cracked, and another tooth you can restore with composite. So Julie is an example of some of these problems. She's got beautiful teeth, hardly any wear on them, generally speaking. Or I should say, basically no dentistry. You can see that there's a little tiny silver filling, a couple of them on the right side, posterior. And however, when we look at her bite, even though she has no wear on her front teeth, her back teeth are touching, not her front teeth. And so when we look closely, and why she came in was complaining of pain, and as I was preparing a presentation with these slides a number of years ago, my 5-year-old son said, "Daddy, why is there a nail in her tooth?" And it kind of looks like that nail caused the crack, and I'm sure it participated in some of the problems, but the tooth actually was fractured, and she lost the tooth. So the maxillary arches, again, not a lot of wear, but certainly the lingual cusps of those upper molars are digging trenches into those lower teeth. You can actually kind of see it if you look closely enough. But so she did lose that molar, and so we had to proceed with doing an implant. And here's the other tooth on the other side, and you can see after the tooth was prepped that there's a large crack in that tooth. The tooth did survive that crack, but you know, how much longer? Hard to say. Oftentimes you put a crown on these teeth, and somewhere down the line it ends up that fracture can still propagate, and you end up with endo and lose the tooth. So that's Julie's treatment at the end point, but we had to establish anterior guidance on her. We had to get her off those back molars, and you can do that. And I ended up having to even grind into some of the metal on the one tooth. But anyway, if you plan better, you'll save more teeth. So formula for success. So we like lists of things, but you really need to know your patient behaviorally. Dr. Pankey liked to say he had never seen a tooth walk into his office. That's a good thing to keep in mind every day your patients walk. We want to do a comprehensive co-examination. Co-examination meaning you want to involve the patient through the examination. You don't want to be just dictating and reading off so that you fill out your forms. You want to explain to the patient. You see something like wear. Why is that tooth worn? Say, oh, I see this tooth is worn, and there's a tooth above it that's pounding into it. We've got like a hammer hitting into that. So they understand, and you're really developing your treatment plan during that examination. So when we talk about treatment planning, this is where it starts, and the patient is already hearing it. They shouldn't be going into your office, having an examination done, and then the next day being surprised by the treatment plan. You want to evaluate the pathology relative to the age of the patient. Evaluate the nature of the existing occlusion. Trial equilibration of your articulated cast. So you need ways to test things out. and test the proposed changes. Especially, this is so important in wear cases. When you talk about occlusal wear cases, I would never go forward with final definitive treatment until I've tested it, typically with a splint. It's more often than not, and sometimes in provisionals when we already know the teeth have to be changed. And we need to learn how to transfer the learning from the splint and provisionals to your occlusal scheme. Splint therapy, we're not going to spend time tonight on this. There was a webinar I did that's on the recorded, saved webinars in the Pankey site. You can go to Splint Therapy. But so splints do a number of things, and very much so it's diagnostic for you and co-educational for the patients, but you're both learning about changes in the occlusion, what they'll do. So it's therapeutic, preventive. You evaluate the effects of what you're doing and how it fixes the systematic system you're testing out, and you want to verify centric occlusion. So you need to have thorough examination and records, and just briefly touching on that, CO bite record, again, centric occlusion. This is not something that I learned very well in dental school. Pankey, when I went to the Pankey Institute, we had some great facilitators and whatnot, and it really gave me my confidence. And once I had that confidence to know where centric occlusion was, that changed my perception of what to do in dentistry. And this is such a huge thing. If you want to treat wear cases, you have to know how to do this. I'd say that emphatically. Like a black, there's not a gray area in that. I think there's a lot of gray area in the world. But in this particular matter for wear cases, if you want to treat them, I'll say this, conservatively, you need to do this and be comfortable with it. Room casts, very important to be able to take good models. You need faceable records, excursive records, so that way you can get your models mounted on an articulator so you can do your examination better patient there. And then with your examination, you want to make sure you're asking the right questions and digging a little deeper into their symptoms and relating it back to their teeth, joints, muscles, and airway. So what's so special about articulators? A lot of people don't use them. My orthodontist and a very good colleague, Dr. Bob Casper, who helped me with that one wear case I showed you, he is one of the few who uses an articulator regularly. And very important, because when you look at simple hinge articulators, and if you're just using triple trays and whatnot, your arc of movement of the jaw is really quite vertical. Whereas in an archon articulator, that's more anatomical, the mandible really moves in forward arc. So your horizontal component is very important to understand as the jaw swings. It's not vertical. If you have a smaller jaw, if you're not using a facebow, you wouldn't see this. In a smaller jawed person, represented by the arrow to the left, we have a more horizontal movement in the pathway. When we have a larger jawed person, you have a less horizontal movement forward. You can get away, in other words, more with a vertical type of movement on a large jawed person. So sometimes you get away with it with what I'll call your snake bite articulators. But you should understand why and when you should be very careful. So centric relation, you keep hearing me mention that word. It's a relationship of the mandible to the maxilla when the properly aligned disc assemblies are in the most superior position against the eminentia, irrespective of vertical dimension or tooth position. It is not a tooth position matter, that term. It's really the jaw relationship. You're born without teeth. You're basically born in centric relation. So when we talk about occlusion, this is a little bit of an analogy. I like to use this with my patients because they understand it very well. If you have a bunch of rocks in a pile and I just pull one rock out of there, who knows how many are going to fall? Maybe a lot, maybe none, but you don't know. So that's a very variable thing. When we have a block like this, if I pull one block out, no matter how many fall, I'm sure anybody pretty much would be able to put this back together in the same orientation. So the analogy is basically a disorganized occlusion is a haphazard pile of rocks. An organized occlusion is a very symmetrical block of blocks. Which would you rather have if you worked on a patient? If you change one crown on a person or have to do a crown on a second molar, do you want them in an organized occlusion or disorganized? That is what drove me nuts when I was younger. I would prep before I understood these things, I'd prep a second molar and I'd find a patient after I went back in my lab. Back in the day, we didn't have these bisacryl materials, and we had to make our temporaries out of acrylic, and I had to make them more often than not. I made them indirectly in my lab, and I go back after being away from the chair for 15 minutes, go back to see my patient, and they were biting on the tooth I had just prepared. And I didn't understand that. That's what led me to more advanced, I would call it, seminars, and why the Pankey Institute is a great place to learn these principles. So centric relation, for those of you who aren't fans of it, people go there with or without you, so don't be offended by these words. It doesn't have to be manipulated, and it's a position of freedom and relaxation. It's neuromuscular harmony of teeth, joints, and muscles. So when the teeth are together, it's centric occlusion, and otherwise your maximum intercuspation will be showing that difference in a little bit here. So you're born without teeth. That's what's demonstrated in the upper left, and when your teeth come in, your joint stays in the same position. And that's the natural way we are. Do we deviate that over time? Sure, we do naturally, just because of wear and tear, the joint can change arthritically and changes do occur. But if all things are wearing equally, it often doesn't change. And you'll see this very commonly in patients who've never had much dentistry done. So here we go again. These are all in centric relation position of the joint itself. And on the right side, you see where we have a splint in there. So now we take a look where we have a habitual bite, and that red dot indicates really where the centric relation position is. And we can see that the mandible in the habitual bite in this particular instance is down and forward. Look at the centric occlusion bite. When we have the splint properly made, it's made to that position of centric relation. That is an orthopedic appliance. That is not the same as just a mouth guard that people buy in a store, or if you're not spending time adjusting these types of splints. So if you want to master finding these positions, you really can practice by mastering using a splint. It's a lot easier than trying to do it on people's teeth and causing problems during your learning. So when we take that splint out then in the person with the habitual bite, we can see on the far right that the patient is actually, when they're in centric relation, has some posterior interferences to the arc of closure. So that's the important concept here to understand. And we're not going to spend more time on this, but you need to know this to be able to treat these wear cases, and you'll see why. So just for terminology's sake, here are some definitions. Again, centric relation, it's really independent of tooth contact. It's the arc of closure. Centric occlusion is in the centric relation position, and then the teeth are touching. Maximum intercuspation is the teeth in contact, regardless of the joint. Has nothing to do with the joint per se. So we'll move forward now into the treatment planning, and this is the nuts and bolts of what we're talking about. How do we apply this stuff, treatment planning, and how do we do the least amount of dentistry to get this done? And through that, we have to do a trial equilibration, wax up on the model sometimes. You have to do splint therapy, verify CO, or do a reversible prototype on the teeth themselves. And sometimes you need your specialist to help you with certain aspects of that. And then we'll have treatment sequence included in these discussions on these patients. So let's start with the patient. So this is what I like starting with when a new patient comes in to start understanding, besides their chief complaint, is just asking them, are you happy with the appearance and the health of your teeth? And that leads to a lot of different discussions. I ask them, what do you expect your teeth to be like in 5 years, in 10 years, in 20 years? Some people are saying, hey, Doc, I really, I want to make sure that I don't have to come back to see you again. So they're looking for a long-term, and that person is looking for an investment. If you got somebody who's up in years or has some serious financial issues, they might just say, hey, I need to get by for a couple of years. And you want to make sure you identify not just what the ideal treatment is, but what is suited to their needs, their temperament for dentistry. So here's Muriel, same lady I just showed you back here, but it's, this is the day of treatment. I think it was at like 7 a.m. And Muriel has some issues that she was concerned about, and basically she had all those white things in the back are the recent dentistry she had that started to fail over the last few years. So she had a new bridge that is now missing at the top right. She's got a new bridge in the upper left that's failing and moves. She has the crown that was failing on the bottom left. She didn't like the color was going on. She didn't like the symmetry of the way the teeth were canted in her gummy smile. She had quite a number of problems, and she had, I wouldn't call it a lot of occlusal wear, but it certainly is related to why her teeth are as they are, is because the wear was not controlled and she didn't have a protective occlusion. So here's her x-rays. We can see all kinds of problems there. We're not gonna go tooth by tooth, but so this is a good system or technique to be making sure when you're thinking about treatment planning, the Pankey-Mann-Schuyler technique. And basically you start with the front teeth. And if you're thinking more about function, you start with the lower anterior teeth, mandibular anterior teeth. If we're concerned more about aesthetics, we're thinking about the maxillary anterior teeth and their positions in the gingival heights of contour. And so you think about both of these at the same time. Sometimes one is going to supersede the other as far as how you treatment plan the case. And then we'll go to the back teeth. The lower teeth are really a functional priority as far as the curvature, Spee and Wilson has said that. And then the maxillary teeth again become more of an aesthetic priority. And again, think about numbers 3 and 4 at the same time. So the treatment plan for Mariel, we want to correct the uneven cant and correct the maxillary gingival heights of contour. We want to correct color. We want to correct occlusion, correct the curves of Spee and Wilson, and stabilize the posterior maxillary quadrants with implants. So when we look at her models, so we did our examine records, gathered a lot of information, and on her models, we can see that that occlusal plane is way off tilt, and her teeth actually have a reverse curve of Wilson. Typically, the lower on the right side, you can actually see the lingual cusps are higher than the buccal cusp. And this is more of a teaching tool, but it can help you understand where your curve of Spee should be. And in this particular case, as in many of the wear cases, after we established her centric occlusion position, we determined that we should open the vertical to give us more room and to establish a better anterior guidance so that we can have a mutually self-protected occlusion from the teeth. So here's a habitual bite. We'll stop for a minute here and look at vertical dimension. Many people have concerns about opening up bites and how stable is it and whatnot. I can tell you, if you're paying attention to centric relation occlusion, centric occlusion, you can manage this rather easily. So here we are with our habitual bite with the joint down and forward, and then when our relaxed bite, I like calling it our centric occlusion, when the muscles are more relaxed, we can see that the person has a posterior interference, and actually we see the chin point is tipped down a little bit. Well, we've kind of opened the bite in that position already, and that then if we look at the position of the joint though, we see that the change in the joint actually went up. So that's actually kind of reducing the open bite if you think of it in the posterior aspect. If you look at where the masseter muscle is, they're basically at the second molar or so and posterior to that. So did we actually change the length of the muscle? I would tell you more often than not, in many of these cases, you're not asking anything for that masseter to do. You're just changing the point of rotation of the mandible. And so you're not truly causing a strain in the musculature many times. Use this to your advantage. The distance, so vertical dimension is the distance between reflected anatomic points, one in maximal and intercuspal position. Centric occlusion is your ally. Use it for your prosthetic convenience and test out the vertical changes with your provisional restorations. We're going to go through some cases showing this. And as we continue with Mariel, so with this technique of Pankey-Mann-Schuyler, we look at the front teeth first. So in this case, I'm treating the front teeth. This is all done in a day, by the way. So this particular instance, I bonded on the lower anterior teeth, raised the vertical a little bit, and then I had prepped the top teeth and started restoring the anterior teeth with my temporary. Excuse me. I also had, I used a number of different types of stents to help me with my reduction and to make my temporaries. And if you look on the posterior right here, or excuse me, posterior left, you'll see that I added some composite, and that was to maintain an occlusal set. That's where I opened up the height of the vertical. So that was very easy to maintain by putting that stop there. What we're looking at in that Mann-Schuyler technique, numbers 3 and 4 together. And as we move forward with different types of segmental impressions and whatnot, there's a number of different ways you can do this, but you don't want to lose your vertical dimension. Points of references, so I make my temporaries before I have all the teeth prepped. I make them segmentally to maintain the vertical dimension, and I can put those anterior teeth back on and know where my posterior stop will eventually be. So this is all done in one day. I manage both putting the provisionals on top and bottom. And this is not that same day, but a couple days after. Otherwise, the gum tissue just wouldn't look that good that same day. But Muriel was doing very well with this. After one day, she was very happy and pleased. And then after some time, we were able to get lower mandibular teeth in. So that's that number 3 and 4 of the Pankey. We kept the maxillary teeth still in the temporaries while we were getting these implants placed. And we, again, am doing these segmentally and impression techniques and make sure I don't lose my vertical. And so we also had some aesthetic perial surgery done so that we could get the gingival heights of contour because Muriel wanted to be gummy. And this is a stick bite, so that's a good tool to use for the lab to have a plane of reference so that you get the correct cant or not create a cant in the occlusal plane. These are the final restorations, and so you can see by the red marks, she's basically her at guidance. Some of it does start in a type of group function with her bicuspids, but basically it's on her anterior teeth, noted by the red marks, and her centric stops in the blue. So in all cases, you want to stick to basically those occlusal principles where the anterior teeth release the musculature in the back, and your anterior teeth will last a little longer. Here's Muriel's finished case, and her before and after. So this is one of Dr. Pankey's quotes. You know, success is such a personal matter. It seems one makes his rules as he goes along. And my idea of success has changed over the years, and I'm sure yours does too. When we look at somebody like Helen had a anterior bridge. Yes.
Can I, we got a question in the chat about how do you determine how much you can open vertical dimension on that case or any case? I think it's a common question.
Yeah.
So wanted to throw that at you. Great case to demonstrate, you know, a lot of different things, especially a centric relation as a reference point in that. So fire away.
Thank you. Yeah, and I started with that case because it had a lot of stuff in it. I'm gonna kind of back down into some simpler things and then end up with another complicated, sort of complicated case. It'll become a lot simpler if you just stick to these principles. It'll look like a very difficult case, and just as this particular lady. So how do you determine how high you can go? I would tell you as high as you need to go generally. There's ways to test it. So you've got to figure out a way to test it. And I will continue to show that. So if you can hang in there, I'm going to run through these cases. And at the end, you'll see a case that was really stretched to the limit. And how did I test it? In these types of cases, a millimeter or two on that posterior aspect, I will tell you, is not much at all. Because when you think of the relationship to the jaw joint, what are you asking back here to do in the jaw joint? Is a millimeter or two here. Back in the jaw joint, the ratio is about 3 to 1. So it's a tiny little bit of change back here in your masseter muscles back here. In the anterior, you may get, if you have 1 millimeter change in your jaw joint position, you may get up to 6 anterior millimeters open. So it's all depending on the size of that jaw too, whether or not they have a more vertical component or they have, in a smaller jaw person, by the way, you can get away with a lot more sometimes. Big jawed people, you got stronger muscles, and you can get away with things too. And actually, the last case is a big jawed person.
So George, it sounds like your principles are that you're presenting are is that centric relations a very precise endpoint or a reference point. Vertical is something you can vary as you need to in order to make to solve problems in the case. Am I hearing that right from
Yes,
George?
yes, exactly. Yes, centric is your position that you can start, how you can maximize your ability to change vertical. You cannot be I would not be messing around with vertical if I did not know where centric was.
Okay.
So
Great.
it's really, really important. And that's not an easy skill to master. I remember it taking me like 3 years early on in my career to try to learn that. I failed a lot of times trying to get it. And so I just didn't commit to doing permanent dentistry as quickly then. Now I have the confidence knowing that I understand that, and it's a lot easier for me with confidence to change vertical. And so those go hand in hand. And then you can stretch the limits a little bit with it. All right. I hope that.
I think that answers it. And just for our attendees, in Essentials 1, one of the main focuses is for a student to leave with the confidence that they can locate, record, and transfer a centric relation record to CAS, and to have the confidence that George is talking about, because I agree completely. So we work really hard on that and employ a variety of ways of locating centric relations so people can leave with that confidence, because I agree, of course, with you. That's critical. So thanks, George.
Yeah. Thank you for emphasizing that. That is so important, and that is like a number one thing. And then learning how to test it out, the splint therapy, and that's the second course. So you spend a lot of time in that area in your dentistry, and your ability to help treat these patients will excel tremendously. So Helen came in, and so she came in, she was in pain, and I was like, wow. I could see why she was in pain. This was after I sent her to the endodontist. She needed 2 root canals. I was surprised she didn't need more. And I asked her how long that bridge was in on top. She said 20 years. So some people might say that bridge was successful for 20 years. I would argue that it was failing for 20 years. So how do we treat a case like this? Well, I bet you I would like to change vertical if I could. And so sure enough, on my wax up, I increased the vertical height of the lower anterior teeth. Helen was already up in her years. She had a partial before. She said, hey, I'm okay with a partial. And so again, I go through making some stents so I can transfer from my workup, my diagnostic workup, to the mouth. And so I can prep my teeth. And actually those teeth don't look too bad when you look at the preps of them. And that was because I had a wax up and I knew where I could reduce. I really didn't take much off of the facial, obviously, and I worked on the linguals of those teeth. And I did also add a little composite in a couple areas, but anyway, so the vertical height, you can see here where it's changed, where we're going to the finish already here. And I had to redo her 7 to 10 teeth also to establish a better interincisal relationship for anterior guidance. So that's your numbers 1 and 2 in the Pankey-Mann-Schuyler technique. And then their back teeth just drop into place with the partial. We have a little drop in the occlusal plane, but that's no big deal as long as things are functioning properly. And she can chew. She did great. So occlusal planes don't have to be perfectly level in a perfect curve of Spee and Wilson to work. It's a nice place when you're talking about aesthetics. And more often than not, it'll look better when you do it right. So if aesthetics is a big concern, but Helen doesn't show her lower teeth, so who cares about that lower occlusal plane? She was thrilled as could be. Kim, she woke up. This is like the middle of the night for her, even though it was the morning, just because she works a second shift, and these pictures were taken back with 35 millimeter. But Kim was at the time about 40, and her teeth were, she was saying, they're discolored and very worn, and she didn't like the way they looked. She's like, my teeth used to be bigger, healthier. I had beautiful teeth when I was young. Put me pictures of them, and I said, wow, they were beautiful. At first I didn't believe it, because I looked at those teeth and I just said they could never have been beautiful. But anyway, we got our models, our records, and here's her maximum intercuspation. She's almost close to an edge to edge. But when I put her in centric occlusion, centric relation occlusion, she had actually basically an open bite. So I was able to fill that space and lengthen her teeth, and we took him from here to there. And that could not have been done without putting her in centric relation. Here's our orthodontic case again from Dr. Bob Gaspers that he referred to me because this patient had some significant wear on his teeth. And he didn't show his teeth, as I said. That was his main complaint. That's his repose position. And it did look like he was missing his teeth most of the time. It took him a broad smile to show teeth. So the patient went through surgically facilitated orthodontic treatment. So it's to speed up the orthodontic treatment. The bite was open in the anterior to gain room. And then we I made a splint out of composite material on his teeth. While he was in orthodontics, I said, okay, how is this guy going to keep breaking things? Can we put, what type of restorations can we put on him that'll last there? Well, this is composite, and that composite lasted. And because we reestablished proper occlusion, we got anterior guidance created. And so that's after we took the brackets off, and I let him sit in this stuff for a while and say, okay, how's he going to do with it? What can I put on his teeth? Really, it's very conservative. I just added onto his teeth. And so I felt comfortable putting him in veneers. And this is the day of cementation. So I veneered from 6 to 11 and 24, 25. He had some bleaching done, and fortunately his teeth bleached up very nicely. That's not any Photoshop of color. He was an ideal patient in that regard, and I had a great orthodontic support. And the veneer seated, and Dan did very well with those, except when he bites on pens, which he likes to do. Don't let your patients bite on pens. Also, if you cover them with a splint at night, and a splint that does the right things. And on this particular patient, I made a maxillary splint. Normally I make mandibular splints because they're smaller, but since I'm covering top veneers, I just know it's going to be. Now here's our kind of our grand finale big case. This is Peter, and Peter, he also about 40. It's kind of interesting, and my mentor many years ago said to me, and for those of you who are around 35, 40, he said, you know, start watching, and you'll see that these people start coming in your office because all of a sudden they're realizing their teeth are either breaking, those old fillings are breaking, they're losing back teeth, their front teeth are breaking down, they're not looking as good as they once did. And sure enough, that happens. So for those of you who are at that age, I remember those words very clearly. I hope you remember mine. Start looking for these issues because they're there, and these people are wondering what they should be doing. Even though they may not have the income maybe or the place in life to be doing a lot of comprehensive dentistry, you can start on that path so that they're ready and you can start protecting their front teeth in particular. So Peter, that's quite a bite. That's the worst bite I would say I've ever seen, I think. And he actually has some primary teeth there, and that's how he would bite down. And it almost looks like he's upside down. And so you can see some retained primary teeth. He even has a primary canine. So it looks like he has 5 incisors on the bottom, because if you look where his cuspids are, he really has 3 cuspids, and one's a primary tooth. So very interesting case to start with. So we brought him into centric occlusion or centric relation. That's the picture on the left. So lo and behold, Peter actually he's class 3 tendency, but basically an edge to edge. But he had learned to protrude his jaw to get his teeth together. I don't know how he learned that, but he did. So anyway, the other thing about Peter is that he was perfectly healthy. He could chew his food fine. He wasn't complaining about anything. He was definitely wanted to look better, but his primary concern really was, can you make things last and make me look a little better? That's basically how he kind of put it. And I said, well, certainly we can make make things look better. I said, about lasting, well, let's test some things out. So Peter's an adapter, and that's a winning case. So when you look at people and what they're able to tolerate, Peter, you could almost do anything in his mouth and figure he could tolerate it. So as I was thinking about what I had to do, I mean, as I talked about earlier, for predictable occlusion and treatment planning, you have to have these things. So I did these things with Peter, and we got our mounted models, and that's his maximum intracuspation bite, and you can get a better look at where those primary molars are down there. And the goal was to find the most predictable treatment with the least amount of dentistry. So we could have crowned all his teeth. We could have sent him to surgery and had all kinds of surgery done. He had plans like that from other people, but he didn't want to go through surgery. He was just like, well, I just need to look a little better and I want this to work. Who can do that for me? And somebody kindly referred him to me. Anyway, so we wanted to eliminate, that's a typo there, sorry about that, eliminate the underbite. Improve the aesthetics slightly, as he said it, and we wanted longevity and function, comfort, and health. He is an investment person, and he was willing to invest in his mouth for the long term. So here I am in centric occlusion on the articulator, and we can see, well, do we want to open vertical that much? Look how far apart those posterior teeth are. And I was just like, well, Peter's an adapter. So to answer that question, how far can you open it? As far as you need to is what I would test out, because you don't have to commit yourself to anything. So I said, hey, Peter, simplest treatment plan I can think of is, and again, following this technique is how I kind of thought through the process, mandibular, the anterior teeth first and then the posterior teeth. So I built up the anterior teeth to give occlusion on those teeth, filled the gap in the centric occlusion. And then I just took, Peter didn't, you know, we were at a point where he didn't want to invest a lot of money in my diagnostics. And I said, well, I don't want to, you know, I'm trying to keep costs at a minimum for you. So I'll just throw some rope wax back here for the back teeth because those we'll just figure out later anyway. Let's get our front teeth in good position and see what we can do. So I was trying to figure out a way to do something reversible for him. And so I made him a splint in that position. If you look at how thick that splint is on the bottom right, it's basically taking up all that space for the wax. All right. So I told Peter, I said, why don't you wear this 24/7? Even chew with it if you can. Eat a couple meals and tell me how you feel. And I want you to wear this for at least a couple weeks. And I asked him to eat all his meals with it for that time, but he said he did it once or twice and was fine. He said, and he came back to me, told me he was perfectly fine with the splint. So again, reviewing the splint therapy, you test out the changes that you're thinking of making in the system. And you're verifying that that is centric occlusion. So Peter had great function on this splint. I gave him great anterior guidance. He was off his back teeth. He was symptom free, never complained. So then we started treatment. So cases like this, I like doing as much as I possibly can in a day. So I did since the anterior teeth are the first part of the Pankey-Mann-Schuyler technique, I did the maxillary anterior because I wanted to improve the aesthetics. And I was concerned about where that vertical was going to end up. So I also built up the back teeth, and I actually just I barely prepared those primary molars, and I just layered that, basically it's acrylic over the top of the teeth. And here's the first day, things are cemented. And we went and said, Peter, go home with this, see how you do. He was tickled pink with that. He was thrilled with it. He came back, said everything was great. So we're like, okay, let's start getting implants in the back, get these primary teeth out and get some real teeth back here. So, because we didn't feel comfortable with those primary teeth and investing in those teeth, so to speak. And so you'll see too that these teeth aren't perfectly anatomically designed. Even like if you look at that posterior right molar, it's just kind of like a blob back there. And you know, Peter's chewing fine, and we're just saving a little bit on some expenses in a way. But I also was playing around with the vertical dimension, and that was an easy way to deal with it. It's just bulked up composite basically on it. But here we have implants now placed. This was after, you know, probably at least close to a year after we had started treatment. And he's actually got the bicuspids, and there's actually the canine on the lower right side is an implant. So now we've got, now how do I transfer this and get some models made? Actually, this was one technique I don't use, but I kind of cut some holes into the tops of these teeth. I took a pickup impression, and you can see the kind of the designs I created, so that way I could seat those temporaries back in there. And then I poured some GI mask in there before I put the stone in. I put GI mask on, and I was able to create a soft tissue model so that I was able to replicate the soft tissue contours. I don't ever try to do a technique except from using directly from my provisionals to make my soft tissue model. If the soft tissue is correct in the emergence profile with your provisionals, you should duplicate that in your final restorations. So I use, we scan these models, and we get, and we can see how nicely developed that soft tissue is now. You obviously need to collaborate with a very good periodontist or surgeon who knows where to place these, so that you basically have some running room for, to create your contours. And so these were CAD/CAM designed at the time using Atlantis. Presently, I use a number of other companies to do my CAD/CAM, but so now we've got the implants in place, we have good tissue development, and I've cemented the maxillary arch now, right? So we've got the whole aesthetic situation lined up. Vertical, we know where we're at because we've had the temporaries in place, and I'm going to, again, go to the front teeth and develop my anterior guidance first before I finish my posterior teeth. So we went ahead and finished the lower anterior teeth, and Peter requested, hey, I want them to look natural, so we put a couple little irregularities in them, and that's why those incisal heights aren't all even. But you really don't see his lower teeth much anyway, as you'll see in his other photography. The other thing, now here's the final teeth. So then we went ahead, after we finished the lower anterior, we finished our posteriors. And the posteriors become rather easy when you've had this all done. So a very complicated case, I think, was really quite simple in essence. And even though you can see those two natural canines never were restored, and actually the bottom picture is reversed, and it should be flipped the other way, but in any case, the canines, he doesn't really show them, and he knew he could do something later. He still has, I just had him send me some new pictures today of what he looked like. This wasn't his picture, this was my clinical picture, but so you can see the clinical finish. And here's Peter. He just sent these to me today, as a matter of fact. And his teeth seem to be glowing on the right. I don't know why. Maybe he did something to him, but he looks great. He doesn't show his bottom teeth, and he's healthy as can be, and readily comes into the office whenever we ask him if we want to get some pictures. So that's Peter. And if you're, by the way, if you're not making mistakes, as I said, which I made plenty of them, and that's how I learned, you're not trying hard enough. And it's okay to make these mistakes, because you will learn. And so please don't hesitate to try these things. And that's why it's great to work in study groups, and be sure you have some mentors that help you along the way and tell you that, you know, your patient's teeth are going to start blowing up when they're like 40 years old. And yeah, hanging near these people, you'll learn a lot. And that's one of my study groups that I work with up in Wisconsin, whole friends up there. And of course, we have our thanks to Pankey, and there's receiving information on how to contact for courses. And that's my 3 children. You can contact me anytime. I appreciate your attention, and all your questions are very welcome.
So George, a couple of people asked if you could put Muriel's photos back up. I think full smile facial photos kind of thing, to just see that. And I'm not sure what the questions are behind that, but they wanted to see Muriel's before and after photos, I think. Yeah.
Do you want to see the end or something in between? Like, here's like, let me get rid of the question here. There's before, is that okay? If you want to see her, is that what you want?
I think maybe like a full smile, whole face.
Sure.
If you have,
we'll go forward from here. Let me go like this. We'll just kind of.
There you go.
And that.
There you go. That's great.
She's got a lot of asymmetry. You look at her chin; it's tipped to the side. It's tipped to her right side there.
Yeah. What do you have any thoughts about that? Because it is. She's definitely canted, and then
she's canted. She's asymmetrical. She probably had some. She might have had. If you look at her chin, she's got a little scar on her chin on the bottom. She probably had some stunted growth. She didn't have anything of TMJ issues whatsoever. So she's got an adapted joint. I only image when I'm totally lost. I love imaging. I think imaging is great, but I find that unless I've got something that I'm completely lost in, I'm not going to, unless you're concerned about medical legal issues, which actually the more you image, the more you're responsible too, by the way. So it's a double-edged sword there. But, I go more so by what the patient's presenting, and then I determine if I really need imaging of the joints. I really don't.
Yeah.
Adapted joint.
Of course. And then do you have a final full facial photo on Muriel to compare? Yeah. I think that was what several people
we'll go. Muriel, where are you? Oops, here. Yeah, that's Muriel. That's
awesome. There you go.
Yeah.
Yeah, there you go. Okay, great.
Her chin is still tipped. If you look at that picture of her face, her chin's still over kind of to the right from center. Her nose point. So trying to figure out, I spent a lot of time playing around where that midline was with her and trying to space those teeth out. That's where you spend a lot of time with the provisionals. And it wasn't easy picking the midline on her. You couldn't just use her philtrum. I mean, her nose was on one way, her chin was the other. Her nose was more to the left, and her chin was to the right, relative to each other. Her nose was actually bent, like mine. But anyway,
No, that's great because you can definitely see the improvement of her incisal plane is more horizontal with her face, and it was canted a lot. Yeah, that's a big That's a big difference. That's a lot of work. So George, I know that part of doing that is taking a face bow and a photo of the face bow to try to find your horizontal plane. So you could have used her interpupillary line, but her left pupil looks a little higher than her right pupil. There you go. You have a stick bite. So you look like you were using just the horizontal axis of her face.
Yeah, and I actually was saying, because I have her provisional in there, I have a segmental provisional. So that was an impression of the teeth at this point with that provisional in. And then the lab was able to orient, because I knew that plane was right on her provisional. So then I took off half the provisional, took an impression of the teeth, the prep teeth, and then put the stigmite in there. So that way they had it to that model. So all he had to do then was create the final restoration on the right side, had the right plane. Then I took off then he could take off the left side or put them on the full impression model. And he's got the work done on the right side, now finish the left side, if that makes sense. So taking the stigmite with the approved provisional in place was the key here.
Yeah. And so what I would just comment on is George is doing a lot of things to create reference points because there were so many missing. We had canted teeth, missing teeth, broken down teeth, vertical was off. And so that's, I think, a real good takeaway is just how hard he worked at creating the reference points, beginning with centric relation to the incisal plane and then using that segmental provisional. That's great. That's a great photo to demonstrate that.
Thank you. Yeah, and I know the explanation and not seeing it, it's kind of complicated. And people, if anybody out there, if they need more explanation about that, and, I could walk you through that, individually somehow, whatever, it's, you're welcome to contact me. But it is making sure you have reference points is really the key, and not losing those positions in the transferring, because labs need a lot of help.
Yeah, for sure. And you separate yourself apart from the crowd when you're doing all that. So when somebody like Muriel, who's lost so much and you're trying to recreate it, then what's required of you to communicate that to the technician and or yourself to get to a final result is much, much more complex. Requires a lot more. Yeah. That's also one way to handle a complex case, is making it simpler by creating those references that you follow to know that you're in the right place.
Correct. Yeah, I think probably the hardest thing in these cases is making sure you're getting that communication to the lab in the right way. So it is creating those that information transfer. And again, that's what I mean. A splint in of itself that's where understanding how to do that, how you can test out different occlusal schemes in a splint can save you lots of trouble in your restorative work because a splint's a lot easier to change than a crown.
Yes, for sure. And the splint therapy allows the condyle to see the joints to adapt and remodel and stabilize before you create your final occlusal scheme.
Correct. Even if people aren't real comfortable with centric relation, if they pay enough attention to their splint, they will typically ultimately get there. The patient will only get comfortable often, or the wear facets on the splint will force you back into almost that centric relation or centric occlusion position if you're really refining the splint.
So there were, and almost always are, a few questions about the vertical dimension aspect. Is there anything that you want to add to that, George, about how you approach that and think about it as a tool in your restorative design?
Yeah, I think, in each of these cases, certainly in every case, I evaluate that. That's the first thing I do when my patients come into the office, because I just give them an anterior deprogrammer. And I didn't show a picture of that, but this is a little simple button on the front teeth. And so they're only touching their anterior teeth. Also, very rarely does somebody come in with such a hot joint that they can't wear that, but it's a good way to test the health of the joints too. But it's the key to the vertical dimension as repeatedly is because you've got space. It's already there to be able to change. I'm really not changing. I really don't believe in changing the vertical dimension, because if you talk about it, it's really the muscle is really what dictates that. That's what dictates the patient's comfort and what's going to happen in the future. The muscles always win. That's a good rule of thumb. Listen to the muscles. What the muscles tell you, you better follow. And if people have ground their teeth in, those muscles have told you, like in that other case I showed you, Helen, with the very, very worn lower teeth, the muscles were saying, these teeth don't belong here. Get them out of the way. So I respected what the muscles wanted. And that just takes attention. And when you're working on that anterior guidance, I would tell you, all you got to do is have people posture out on their front teeth. In a natural dentition, they'll posture there very readily. In a contrived dentition, or changed dental, iatrogenic dentition, I'll call it, people will quiver on their front teeth. They're not stable sometimes, and that tells you you need to refine that guidance. You need to give them more landing points on their front teeth for them to have stability. Come off their back teeth often. So just watch what the patient does when they move their teeth around, and you will develop a much better occlusion. And for those of you who aren't comfortable with centric relation, you can start on the front teeth. Just start doing, as I said, that those little changes on those anterior teeth, those first few cases I demonstrated of the incisal wear of those slightly worn dentitions, depending on the age of the patient, which just bring up the case again, that's where you start your treatment plan anyway. So whether you're in centric relation or not, work on those front teeth, start doing this stuff, and you will work out to pretty much centric occlusion if you're paying attention along the way. Doing some things, you can get there more readily and start doing some occlusal changes. So don't be afraid to start doing these things. You can do these things safely. I would be careful with vertical dimension of changing that until you're comfortable with centric relation, because that's where you can get in more trouble.
You bet. So George, one last thing here. It sounds like what I hear you saying is that the patient experience during the comprehensive exam is really the key to them understanding their problem and understanding a direction to solve that problem. It sounded interactive what you were doing.
Yeah, yes, and the comprehensive exam, again, the best course I took for doing that was at Pankey. That changed. I already knew how to mount models. I knew where centric relation was before I came to Pankey. I knew a bunch of these things, but I really didn't have those tools of that behavioral and communication of how to do this examination and tie it back to the patient, which is a huge difference when people say, well, I have trouble getting people to accept my treatment plans. I will say that you probably didn't do the co-examination. You probably didn't have the patient understand and doing these simple exercises with the muscles. That is a co-examination, and palpating the jaw muscles and palpating the joints, and saying that, for example, if you see that a person had a crown placed or some new veneers placed on their front teeth, and you palpate the joint and it's hot in the posterior aspect, that is typically because the contours of those crowns on the anterior teeth are pushing that joint back. And you can relate that for the patient to say, hey, the reason why these front teeth are wearing like this and you have this hot joint, they're tied together. And so the patient knows, well, what do we have to do to change it? Well, we have to change your bite. We have to change that crown or whatnot, whatever that treatment. We have to do some different things with bonding on your front teeth to get this occlusion leveled off for you. We have to give you stable stops. So when the patient understands that their muscles and their body is deteriorating, because most patients don't know their joints are sore. Very few people come in saying, yeah, I'm really sore in the back of my joint. I mean, I had a call tonight, by the way, from a patient right before this started. Some woman called up on an emergency, basically, a patient calls a dental emergency, and she was complaining of these severe pains she was having. And she went to the endodontist at the end of the day, and the endodontist said, you don't have an endo problem, you have a joint problem. And so hence she called me, and she was totally unaware of that it really was that her headaches were emanating from her joint. So relating that physical examination to what you see on their teeth, and when they feel that discomfort, and when you palpate muscles, most people have some pain in their muscles. They've had dentistry. Unfortunately, they do. That's the co-examination.
Yeah. So final question. It's 8:14, and so we need to wrap up. There was a question about the class 3 tendency occlusion with more of an end-on anterior relationship, and how do you create anterior guidance that's acceptable in that kind of a situation? Is there anything there you want to address? Because I was trying to answer questions in the chat as you were lecturing, so I didn't get every
Sure.
jot and tittle of your lecture.
Yeah. Great question. You can see my screen, so right?
Yes.
Okay. So let's go to the model. So that's maximum intercuspation. They're actually protruded. So that means their condyle is down and forward. They're in a protruded position. So that is skeletally termed a pseudo class 3 because they're not in centric position. The only way you really can skeletally relate, and orthodontists, and not just orthodontists, I don't mean to by any means pick on them, but if you're not taking a record when the person's in centric relation, you really don't have the proper skeletal relationship. So I always challenge my orthodontists, please make sure that when you take imaging that you're in the closest you can be to centric relation, so that we get the proper draw relationship. So with knowing that his centric, so I know how to take a centric bite record. This was his mounted models on the articulator. So I had to protrude on the articulator to get his teeth into that position, here to there. And so then I just filled in the spaces. If you look from here to there, all I did was, where if you see my mouse, I added wax here. I just waxed it up. And then in the back, I did the same thing. I just filled in all these gaps with rope wax, and I kind of carved a little contour into it. This took me 5 minutes to do with the wax in the back instead of having to wax up full contour teeth. Saved Peter a lot of money instead of me sending it off and getting and usually I do all my own wax ups, by the way. It's a great way. If you don't do your wax ups, I will tell you it's a great way to learn how to do your composites. So it is worth doing, and it's very quick to do, and I actually enjoy waxing up. But today I'm moving more toward digital wax ups. It is a lot easier. So here's the splint. So basically what I did was fill in the gaps where the teeth were missing to create that same vertical position. This is even more vertical open than what he is with the teeth. Some people say test vertical with a splint. I really rarely, in this case, I did test vertical with a splint. I rarely ever would say I test vertical with a splint. But in this particular case, I really did. This was in lieu of putting temporary crowns on all his teeth. Peter was not, we knew he needed dentistry, but he wasn't sure, nor was I, would this work? And his other option was surgery, basically, other than this. It was a jaw surgery. And so we figured, hey, let's give this a go. The only way outside of putting temporary crowns on his teeth to test it out was build a splint that acted as if it were temporary crowns. And so if we look at the guidance on this splint, is that left and right excursive movements he released on his back teeth. I gave him anterior guidance. And if we do that jaw muscle exercise again, as soon as we're off those back teeth onto the front teeth, the muscles diminish, they release. And so Peter was like, oh yeah, I feel great with this. This is as good as his teeth ever felt. And again, Peter's an adapter. If you have the princess and the pea, oh, by the way, the splint, it teaches you which patients not to work on. Also, like you get a person, my God, you think you've got everything right, and they just keep saying, no, something's wrong, something's wrong, something's wrong. Well, that person, either if you're going to work on them, you're going to have to charge them more, or you're going to have to give it away, or drive you and the patient nuts, or they leave you. So did that answer the question on the splint? So that gave me the confidence of then going forward with provisionals and prepping the teeth. It gave the patient the confidence. That sold the case.
Yeah, I think so. And then so what George did was he articulated casts with a face bow, took a centric relation bite record, took advantage of the fact that the mandible fell back a bit, so it wasn't as class 3, and so he was demonstrating with that first point of contact there. And then in Essentials 1, we learned how to take a protrusive bite so we can set the condylar inclination on the articulator, and that inclination, meaning how steep the eminence is and how quickly teeth disclude or don't disclude in excursive guidance, then it begins to tell you with an end-on relationship, can you gain disclusion? And here he did, or the patient did, if I'm saying that right, George. Yeah. And so those are the skills that I think are really, really critical to learn in advance on the models, as George did here, what happens with the patient. And without the protrusive bite and setting the inclination in the articulator, which is very simple to do, you don't really know. And so it's kind of this increases predictability. Is that a fair thing?
Yes, definitely. As far as, again, the excursive records and the eminentia and the use of articulators, they are good assimilations, and they give you pretty good ideas. And never think that the articulator is the same as the patient. Of course, the true articulator, as we always emphasize, is the patient itself. So it gives you a very good ballpark. It gives you an idea of what you're able to do and help you treatment plan the case. But you certainly need to find, I would never trust, there are people who believe that you can do this all on computers and everything comes out smack dab perfect. That's anybody says that, I would say they're not paying attention to certain things.
Human beings are more complex than an articulator and any digital device. The algorithms aren't quite that good yet. They're close, but they're not.
Yeah, I don't know. Yeah, it'll be tough until you can have muscles in there and everything else, because those muscles tell you a lot about what's going on.
They do. So I know we're at 8:20 now, and I think it's probably time for us to put a wrap on this. But anybody that wants to reach out to George with questions or wants a conversation, I know he'd love to do that. So his contact info was in the chat that Dylan put up there, and reach out to George. And what a great presentation. It's really a lot of learning to go on there, and kind of a great step. I think in the essentials, there are specific training teaching points that really help guide you through this. But as George said, for sure, the ultimate articulator is the patient and having to test it there. So thanks, George, for great presentation and for your time. And people that want to talk more, just reach out to him.
Yeah, and go visit Mac too.
Absolutely.
He'll be teaching some of these same things. So thank you, Mac. You did a great job in helping consolidate some of these thoughts, and I appreciate your support and everything you're doing for us.
Happy to do it. Great presentation. Come back to Pankey Online. You'll find more great courses there, and we'll see you then. So thanks to Desi and Dylan for providing all the technical support and making this happen.